Good afternoon. Thank you for the program committee for the honor of presenting to you today. I will say I'm presenting this on behalf of my fellow Mohammed Zaidi, who did all the work for this study. We have no relevant disclosures. So as the group knows, functional neuroendocrine tumors are less common than non-functional neuroendocrine tumors, and they comprise about a third of the neuroendocrine tumors that we diagnose in our patients. And the function and the syndromes that are associated with it are usually associated with a hormone such as insulin or gastrin, as you can see here. And they have a very distinct clinical presentation, with insulinoma and gastrinoma being the most common, with the hypoglycemia and the Whipple syndrome, as well as the ZE syndrome. And most of these functional neuroendocrine tumors are actually sporadic, but some of the times they actually can be part of a familial syndrome, such as MEN1, of which the most common is gastrinoma, and then VHL, as well as NF1 and tuberous sclerosis. However, it should be emphasized that still the majority of the neuroendocrine tumors in these syndromes are still non-functional. And if we look at the outcomes of patients with functional versus non-functional, you can see in the blue line, the patients with functioning tumors often do better than patients with non-functioning, presumably due to an earlier stage of diagnosis, again, due to the clinical syndrome associated with the hormone that is secreted from these tumors. So patients with functional neuroendocrine tumors undergo resection to often relieve hormone-specific symptoms, but also for oncologic reasons. And even in the metastatic setting, resection is associated with symptom improvement and extended survival, i.e. cytoreductive procedures. So this suggests a potential interaction between symptom control and oncologic control that may potentially just go beyond just the active removal of active disease. So our aim was to define the association between the failure to achieve symptom improvement after resection of functional neuroendocrine tumors and the clinical outcomes. And we hypothesized that the failure to achieve symptom improvement, even in the absence of radiographic present disease, would be associated with a decreased recurrence-free survival as measured by radiographically evident disease. So to do this study, we used the power of the U.S. Neuroendocrine Tumor Study Group, which is a compilation of 8 institutions you can see listed there. And we included all patients with functional neuroendocrine tumors who underwent resection over that 16-year period. And we compared patients with and without symptom improvement, with our primary endpoint being recurrence-free survival, importantly as measured by radiographic evidence of recurrent disease. So in the database, we started with over 2,100 patients. We removed those who had non-functional disease, and we excluded the carcinoid syndrome. So these, again, are just hormone-specific syndromes. And we were left with 262. And then we excluded patients who underwent cytoreductive procedures with R2 resections, i.e. gross disease left behind, which left us with 230 patients who underwent a curative intent resection of a functional neuroendocrine tumor. You can see the baseline variables there. The average age was about 52, about half were male, and then only about 20%, as I mentioned, were involved in these genetic syndromes, with, again, the majority of these being sporadic. The most common was gastrinoma and insulinoma, with, again, insulinoma being the most common. Now, in terms of pathology data, as you would expect, only 16% were multifocal, again, going along with the fact that most of these were sporadic and likely solitary. Size was usually pretty small, given their early clinical presentation due to syndrome. Majority were in the pancreas, and most, again, had one tumor. As we would expect, most were well differentiated and had a low Ki-67. The lymph node positive rate was about 22% in the patients who underwent resection. And of these patients who underwent a curative intent resection, 80% underwent an R0 resection, and about 20% had a microscopically positive margin. Again, patients with R2 resections were excluded. In terms of their postoperative outcomes, these are all pancreatectomies, so there was a reasonable complication rate of 50%. And we look at symptom improvement. About half of the patients reported symptom improvement. These were gathered through the medical record, looking at the clinic visits and the H&Ps, and just basically documenting the interviews with the patients. Only about 8% or 7 to 8% did not declare symptom improvement. And unfortunately, about 45%, we actually could not glean that data retrospectively from the charts. The median recurrence-free survival was 20 months. So if we look just overall at the entire population, again, now just isolating to those patients whom we had data on symptom and no symptom improvement, the patients who had no symptom improvement shown in green had a decreased recurrence-free survival, as you can see there, with a 3-year recurrence-free survival of 50% compared to 80% of those patients who had symptom improvement. So what were the other factors associated with symptom improvement? Well, patients who had a genetic syndrome were associated with lack of symptom improvement, as we would expect, as they often have multifocal disease, and those patients undergo cytoreductive procedures. The presence of a gastronoma was associated with lack of symptom improvement, again, being most commonly associated with MEN. And interestingly, although R1 resection status, as you would expect, was associated with lack of symptom improvement, as a third of them did not have symptom improvement, still almost 10% of patients who had a documented R0 resection or negative margin resection still had lack of symptom improvement. And when you look at this in a univariable Cox regression analysis, you can see all those factors: type of functional tumor, genetic syndrome, lymph node positivity, margin status, as well as failure of symptom improvement were all associated with early recurrence. And when plugged together in a multivariable analysis, now thus taking into account failure of symptom improvement alongside all those other pathologic factors such as margin, the type of tumor, still, actually, failure of symptom improvement was the only factor in that multivariable analysis that held true for being associated with early recurrence-free survival, decreased recurrence-free survival. And when we look at, just as important, when we look at just those patients who had an R0 resection, again, you can see those patients, although small numbers, but those patients shown in green had decreased recurrence-free survival of a 3-year recurrence-free survival of only 36% compared to 80%. And you can see that the curve actually comes down fairly quickly, so they're recurring fairly quickly within that first year. And again, these are all patients who had a documented R0 resection. So there's many limitations to these types of studies. It is a retrospective design. However, it does include 8 institutions, so it eliminates single institution bias. It is a small database, yet again, a relatively large database for a rare tumor. Now, the missing data on symptom control is problematic, but again, we did the best we could in terms of going through the charts, and we could not glean the data on those patients. So what does this mean? The failure to achieve hormone-specific symptom improvement after resection of functional neuroendocrine tumors is associated with decreased RFS. And this association persisted even when considering resection status, lymph node positivity, the presence of a syndrome or hereditary tumor syndrome, and the type of functional tumor. So what would we do with this type of data? Well, symptom control may serve as a perceptible measure of oncologic control. And one would say, well, that's pretty easy. If you have an R1 resection, there's likely microscopic disease, so that explains it. But symptom persistence, again, may be a surrogate for the presence of micrometastatic disease, not necessarily at the margin. Many of these patients in their recurrence actually were not recurring locally, they were actually recurring distantly. So just because there was an R1 margin does not mean that they're going to recur locally. And failure to achieve symptom control may be a selection criteria for future trials assessing adjuvant therapy. As this audience knows, there's no standard of care for adjuvant therapy after resection of neuroendocrine tumors, especially for R0 and R1 with no evidence of radiographic disease. But as our armamentarium improves and the number of drugs and PRT and interventions arise, potentially one could imagine there may be adjuvant trials, and perhaps if we do include functional tumors, those with lack of symptom improvement given the early recurrence would be potentially a selection criteria for patients enrolling in trials like that. And probably the most relevant clinical application of these data would be that patients with symptom persistence would probably warrant short interval radiographic surveillance. Oftentimes, radiographic surveillance is on Q6 month or even usually annual surveillance after resection. So maybe those patients who have symptom persistence should undergo short-term imaging, as you saw based on that curve of patients who underwent R0 resections. Many of them occurred within that first year. And that would actually allow earlier detection of radiographic disease and potentially earlier therapy. Thank you very much. I'd be happy to answer any questions.
Thank you for the nice presentation. I have a question there, Giovanni Butturini. Giovanni Butturini. Yeah.
Can you hear me?
Yeah, I can hear you.
I'm just wondering the utility of your study.
So, you're wondering what status?
The utility. Why did you present the result? Because it is normal. If you operate a gastrinoma, you know that 90% occur. So it is normal. What you say, I don't understand the hint. What do you want to suggest?
Right. So the main thing, again, is just because you operate on a gastronoma, if it's a solitary, sporadic, non-familial gastronoma, actually, you shouldn't expect them to recur. Hopefully, you're doing that for the curative intent. Now, I agree, if it's part of MEN1, they're going to recur. But most of these patients, as I showed you, only 20% of these patients were part of a familial syndrome. So the point is, again, just because they have symptom control and you don't see anything, I think the point is that earlier radiographic surveillance is probably a good idea, and maybe changing our paradigm compared to patients who do have symptom control, because it's likely a representation of micrometastatic disease somewhere that actually, based on these data, again, limited patients, but the radiographic recurrence of disease happens very quickly, at least in this cohort of patients. And that's the key here.
Thank you. So, yeah, I agree with you. I mean, if a message could be, if there is no symptom control, then you expect a worse prognosis. But you have in your database, we're talking about 17 patients only, right? And that was something like, I can't remember, 7%. And also, I saw down in that table that 4.7%, if I remember well, had reoperation. Did you go to see what happened to the 17 patients after? They didn't have symptom control, but what happened? Did you have any data to say, have they been diagnosed with recurrence? At what time? Are those the patients which been reoperated on? What happened to the others? Do you have any data on that?
Right, yeah, so as I showed you, the majority of those patients without symptom control, you can see that the recurrence-free survival was not all of them recurred radiographically, but the majority of them who recurred, as you saw, the median 3-year recurrence-free survival was only 30%, and the majority of them recurred within 1 year, and the majority of recurrences were distant, not local regional. They were not at the site of resection and not lymph node. Now, in terms of how each one of those was treated for the recurrence, that I don't have that data for you off the top of my head, in terms of re-resection versus octreotide therapy and how they were treated.
So can we speculate that there was micrometastasis at the time of surgery, and this is...
Right, I mean, that would be the assumption, again, that the fact that majority are recurring distantly. But I think the key is that I think most patients who undergo neuroendocrine resection are kind of put in this regimen of surveillance that's pretty loose and it's usually pretty sparse. And I think, again, these functional tumors represent a minority of the patients that undergo resection. So just to comment on, of patients who don't get that symptom control, tight surveillance may be good because their recurrence pattern is very quick and usually distant.
It's a very important point, and it's a very important group of patients. So it's nice to know more about them. Yeah, please.
Radiographic. This was the recurrence in this study was defined as radiographic, because biochemical and symptom would just be persistence of disease. But no, this was radiographic recurrence. So something actually that you could target either with ablation or TACE procedure or even re-resection.
Do we have another question or comment? Yes.
Is there any chance, since these are not easy to detect radiographically in the liver, is there any chance that the preoperative imaging failed to demonstrate some amount of liver involvement before they have this?
Yeah, no, that's a great question. I mean, very, very possible. Again, our group is 8 academic centers, and these are all fellowship-trained places or fellowship-trained surgeons. And presumably during the time period, now the quality of the imaging even from 2000 to 2016 has changed, but presumably the state-of-the-art imaging that was available at each of these institutions and utilized. But that, again, in a retrospective study, I can only assume that given the cohort that we incorporate in our group.
Okay, any further questions?
And now with PRT, who knows, it depends on how, not PRT, with 68 gallium dotatate scanning, depending on how available that is and how often you use it, it potentially will pick up these micrometastatic things, potentially.
Thank you very much. Thank you. We close the session. Thank you, everybody, for your attention. Thank you.